Alright guys, welcome to chapter number 10. The chapter number 10 is a continuation of our last chapter, so it's not a continuation, it's actually the start of the endocrinology section. In this we'll be discussing diabetes mellitus type 1, type 2, DKA, HHS, hypoglycemia, diabetic complications, and gestational diabetes mellitus as well. And in the next 11th chapter, we have the continuation of endocrinology. We'll be seeing the hypothyroidism, hyperthyroidism, thyroid storm, Addison's, Cons, pheochromocytoma, and Cushing's disease as well. So to start off, we'll be going over the two different types of diabetes, and I think at this point, if you are graduating, you should be thorough with these as well. But just to have a brief review, that type 1 diabetes is an autoimmune destruction of the pancreatic beta cells, and there's absolute insulin deficiency, whereas type 2 diabetes mellitus is insulin resistance, and there's relative insulin deficiency, and there's progressive beta cell failure. Whereas over in the age where the main differences come is that type 1 diabetes is usually in younger population with younger than 30, and it can occur at any age, and it's an often acute presentation, whereas type 2 diabetes is a later life pathology, occurs in more in people who are more than 40 years, and increasingly it's getting younger, and it has an insidious onset. Then the body habitus is the main difference, is that type 1 usually has a more lean and normal weight, whereas type 2 is usually overweight on obese patients. Then the autoantibodies that are affected are GAD65, IA2, ZNT8, and anti-insulin antibodies are positive in these patients, whereas autoantibodies are not present in type 2 diabetes. Alright, the onset of type 1 diabetes is going to be rapid from days to weeks, and DKA is a common presentation because it's an acute exacerbation of diabetes mellitus, and the patient does not know they had diabetes mellitus. Whereas for type 2, it's insidious, often asymptomatic for years. Then treatment, insulin is mandatory for type 1, because it doesn't have any endogenous insulin production. Whereas for type 2, we can go for lifestyle modification, metformin, and then we have add-ons such as SGLT2 inhibitors, GLP-1, SUs, and insulin. Then both type 1 and type 2 have this overlap where their complications are same over time, such as macrovascular complications, which is more common in type 2, and CVD is the leading cause of death in type 2 diabetes mellitus. Then the diagnostic criteria for diabetes: firstly, we test for fasting plasma glucose. Alright, if it's more than 7 millimole per liter on 2 occasions or with symptoms onset, then it's going to be most likely that it is the diagnosis of diabetes. Pre-diabetic is 6.1 to 6.9. Alright, then OGTT for 75 gram 2 hour is supposed to be more than or equal to 11.1. For diabetes impaired or pre-diabetic is 7.8 to 11. Then random glucose plus symptoms, again more than 7 or equal to 11.1 millimole per liter, plus polyuria, polydipsia, and weight loss. Alright, then HbA1c is going to be more than 6.5% or more than 48 millimole per mole, and 42 to 47 millimole per mole is considered pre-diabetic, or 39 to 47 is pre-diabetes. Alright, and the screening for type 2 diabetes is going to be FPG or HbA1c every 3 years. Alright, from the age of 45, and earlier there are risk factors such as obesity, PCOS, family history, gestational diabetes history, and ATSI. Alright, and OGTT is the gold standard for GDM, 24 to 28 weeks gestation. Alright, OGTT again is going to be oral glucose tolerance test, and for gestational diabetes we do that at 24 to 28 weeks of gestation. Then type 2 diabetes management, first is always going to be lifestyle modification, because we can drop the HbA1c by 1 to 2% by changing diet, reducing simple carbohydrates, portion control, aerobic exercise at least 150 minutes per minute per week. Then weight loss target should be 5 to 10% of the actual weight of the patient. Then moving on to the pharmacotherapy, we start off with metformin, which is supposed to be 500 mg OD with meals and titrate to 1000 mg BD. First line pharmacotherapy mechanism is going to be reducing hepatic glucose output. Side effect could be diarrhea, nausea, and we take with food, and it is contraindicated if there is kidney failure. So eGFR less than 30 or iodinated contrast, it cannot be, it has been held for 48 hours. So if they have iodinated contrast, we hold metformin for 2 days or 48 hours. If the patient has severe hepatic disease, alcoholism, or lactate acidosis. All right, then add on for high CV risk, heart failure, or CKD. We add a SGLT2 inhibitor such as empagliflozin, and this is the most common one that I've seen in exams, and it reduces MACE and the HF hospitalization, so heart failure hospitalization, and reduces renal progression. And we use early in T2 in type 2 diabetes, and it with the established CVD or heart failure or CKD. And it is also recommended in HFrEF regardless of diabetes status, as we saw in the heart failure lecture as well. Then number 2 would be to add on for high CV risk and weight loss if it's desired, and this is the drug that's getting very, very common, which is the GLP-1 receptor agonist semaglutide. It's getting very famous right now, and it reduces MACE, promotes weight loss, significant weight loss, and it also reduces CV events. Side effects, again, with weight loss, with reducing diet or reducing absorption, is going to be nausea and vomiting. Sometimes it can lead to pancreatitis, and we avoid in family history of medullary thyroid carcinoma. Then add-on, which is cheaper and more established, is sulfonylureas or SU, and it has a risk of hypoglycemia, especially glibenclamide, and weight gain. All right, and it is PBS listed as second line in Australia. All right, so glibenclamide is OD is preferred to, and glibenclamide is, we avoid those in elderly patients. The second step, which with add-ons, is going to be, again, so all of these, so first line was pharmacotherapy, metformin, and then all of these are different add-ons. So 2 is all add-ons. All right, DPP4 inhibitor, so sitagliptin, sitagliptin. It is a weight neutral drug, and it has a good HbA1c reduction, and it is well tolerated, and we avoid saxagliptin in heart failure. All right, then if it's still inadequate, this is the third step we move on to, which is basal insulin. We have to give them insulin once daily, and we add to the oral agents, and we start with 10 units, and we titrate by 2 units every 3 days to fasting BGL, and target is going to be 4 to 6 millimole per liter. All right, the target HbA1c individualized is generally less than 53 per millimole per liter, or less than 7%. For younger or newly diagnosed is less than 6.5. Elderly or comorbid is supposed to be less than 8. And we avoid very tight control in the elderly because of the risk of hypoglycemia. And you have to, make a balance between tight control versus hypoglycemia risk. All right, now moving on to one of the most important topics, DKA. We've seen a lot of questions about these, especially for the step-by-step management for these patients. All right, so DKA triad is hyperglycemia, whereas blood glucose level more than 11 millimole per liter, plus ketosis, ketones more than or equal to 0.6 millimole per liter, or urine ketones double positive, plus acidosis, because it's DKA ketoacidosis, so pH is less than 7.3, or bicarbonates less than 15, and most common in type 1 and can occur in type 2 as well. Precipitants are infections, any types of stress, missed insulin, or new diagnosis of type 1 diabetes, or SGLT2 inhibitors. All right, because they can also be something known as euglycemic DKA, where the glucose may be normal. All right, now the management steps, the very first one, before giving any drugs, anything, we give them fluid first. So before insulin, we move on to fluid first. We have to give them normal saline for 1 liter over 1 hour the first hour. Then we give 1 more liter second hour, 1 more liter over 1 more liter over 2 hours, 1 more liter on over 4 hours, then 1 more liter after over 8 hours. Because the fluid is going to treat shock, restore circulating volume, and improves acidosis. Then the second step, after fluid, we move on to insulin infusion, but it obviously is not before fluids started and potassium known. All right, so insulin 0.1 units per kg per hour IV infusion. We do not give that as bolus, and we do not start if potassium is less than 3.5. All right, because as we know that insulin can cause the potassium to move into the muscles and leading to severe hypokalemia. All right, then we move on to potassium replacement. Because of DKA, it has a depletion of the total body's potassium concentration, and we need to add more potassium because insulin and glucose is going to drive potassium into the cell, and if the serum potassium falls, we add more potassium chloride to it, because we need to avoid hypocalcemia in these patients to reduce the deterioration of their condition so that we can manage it. All right, so first fluids, then insulin, then potassium, and insulin is not given unless if the potassium is lower than 3.5. All right. And then step 4 is going to be we monitor the patients. We monitor the hourly BGL and UEC over 2 to 4 hours, VBG and pH plus bicarbonate every 2 to 4 hours. Then we continue the insulin infusion until the pH is going to be more than 7.3 or bicarbonates go over 15 and the patient is eating. All right. Then we treat the the precipitants factors such as the infection. We have to check urine, blood cultures, empirical antibiotics if sepsis is suspected. Then we transition to SC insulin, so subcutaneous insulin when they're eating. Their pH is normalized, and then we give the first SC insulin dose and wait 30 to 60 minutes before stopping IV insulin infusion. All right, now DKA versus hyperosmolar hyperglycemic state. DKA is seen in type 1 and type 2, but HHS is most commonly seen in the elderly with type 2 diabetes. Glucose has a moderate elevation, whereas for HHS it has a very high elevation. Ketones are present in DKA, whereas for HHS we have minimal or absent ketones. All right. pH carbonate, again, acidosis less than 7.3 or less than 15. For HHS, pH is usually more than 7.3. Osmolality is mildly elevated, whereas for HHS it is very, very high considering the fact that there's a lot of glucose in the blood. All right. Mortality is 1 to 2% for DKA, but for HHS it's very high because older patients come with comorbidities as well, and there are other conditions with normal patients as well, so to a very high mortality rate. Fluids, normal saline, but for HHS we give 0.9% NaCl. We have to give them a gentler, slower rehydration and to correct over 48 hours to avoid cerebral edema. Remember, for DKA we're giving these fluids for 8 hours, and over here we give them for 48 hours. All right, now the insulin for DKA is going to be insulin infusion after fluid resuscitation, whereas for DKA for HHS we start IV insulin at low rate, so 0.05. Over here we were using 0.1. all right, and the fluids often sufficient alone initially. Then for DKA, the risk of DVT is moderate, whereas for HHS, because of the high osmolality, the DVT rate is very high for HHS, and for that we have to give them prophylactic low molecular weight heparin routinely. All right, now moving on to hypoglycemia. What does it mean? Hypoglycemia is blood glucose level less than 4.0 millimole per liter, even if the patient is asymptomatic. Now mild to moderate would be the patient is conscious, can swallow 15-gram fast-acting carbohydrate and glucose tablets, or 150 milliliter of regular juice can be given 3 teaspoons of sugar, and we recheck the BGL in 15 minutes. And if still less than 4, we repeat the glucose that we're giving the patient. So the 15-gram fast-acting carbohydrate glucose tablets. So all of this is fast-acting carbohydrate. Then if the patient is severe, unconscious and unable to swallow, we give them IM glucagon 1 mg, all right, or IV glucose 50 ml or 50% dextrose, all right, D50W. And we recheck again a BGL for 10 to 15 minutes. Then after treatment, once the blood glucose level has gone up to 4, we give them complex carbohydrate snacks, so breads, biscuits, to prevent recurrence. Important fact is that we do not let them drive for minimum 45 minutes after treating hypoglycemia and BGL, which has been confirmed to be more than 5 in these patients. Then the common causes while the patient has diabetes is sulfonylurea, especially long-acting ones, or missed meals where the patient took insulin dose but did not have any meal to go with it. Now, diabetic complications, as we spoke about type 1 and type 2, is that diabetic retinopathy, this is the most common one with microaneurysm. We have dot blot hemorrhages, hard exudates, which are non-proliferative, new vessel proliferations, and we can see those in fundoscopy as well. And these, the most common cause of blindness is working age-related adults in developed world. All right, so most common cause is going to be diabetes in working age adults in developed world, and the screening would be for the patients to have annual retinal review from diagnosis of type 2 diabetes or 5 year after diagnosis of type 1 diabetes, and laser photocoagulation for proliferative, and anti-VEGF bevacizumab for diabetic macular edema. Right, so this is the management for these patients. Then diabetic nephropathy, most commonly known, microalbuminuria of 30 to 300 mg per day. Macro is going to be anything more than 300 mg per day, and which means that the patient has CKD, and then they can develop ESRD. And the most common cause of ESRD in Australia again is diabetic nephropathy. Again, we do an annual ACR, albumin creatinine ratio, plus an EGFR. ACE inhibitors or ARBs are renoprotective and reduce intraglomerular pressure and slows progression, and BP target for these patients is supposed to be less than 130 by 80, and we went over this in our hypertension video. If you haven't seen this, go check it out, it's already posted. Then diabetic neuropathy, it has peripheral with glove stocking, sensory loss, pain, numbness, burning, and there's going to be less sensation, so less the patient is going to have less pain feeling, the patient is going to have numbness and burning, so it's more common for them to have wounds and ulcers that go undiagnosed or untreated because they can't feel them. All right, then so we have something called the autonomic gastroparesis, postural hypertension, and neurogenic bladder. Mononeuropathy is going to be CN3 palsy, and it spares the pupil and differentiates from PCOA aneurysm because PCOA does not spare the pupils. All right, then the screening is going to be annual foot examination, monofilament testing, where we take our filament and we touch the patient's feet, different points to check if they still have the sensation. Then gabapentin, pregabalin, duloxetine for painful neuropathies, and metoclopramide for gastroparesis. Then diabetic foot, most commonly seen in the ED, is neuropathy plus peripheral vascular disease plus ulceration, which causes infection, and we have osteomyelitis, and this leads to amputation because of the extensive infection. It is the most common cause of lower limb amputation in Australia. Then we have to again regular foot inspection, early referral to podiatry, IV antibiotics plus debridement for infected ulcers, and vascular surgery for ischemic ulcers. Then macrovascular is going to be CVD because diabetes, especially diabetes type 2, is going to lead to CVD, and is the leading cause of death in type 2 diabetes because of accelerated atherosclerosis. Then for this, we have to give them statins. All right, all type 2 diabetes plus CVD or more than 40 years plus or equal to more than one risk factors. Aspirin if they have established CVDs, and the goal of the BP is going to be less than 130 by 80, which was the same as our nephropathy, and obviously smoking cessation must be done. All right, so this was the management and the screening for these diabetic patients, and these are the different questions, important ones from each topic. And yeah, if you guys have any questions, let me know. Join the Telegram group to get these chapters and to get the previous chapters, to discuss recalls and discuss questions. Again, all the links are in the description below. Hope you have a good day, and thank you for sticking around.